as I said, we're delighted to be here again for the fourth of our 7 talks this fall. We are thrilled that Charlene Wong has been willing to give her 7 talk on Zoom with us. And Charlene, I am more than delighted to hand you the mic.
All right, well, thanks so much, everyone. Really thrilled to have this opportunity. Just add it to the list of times we're on Zoom and WebEx and Microsoft Teams and other virtual platforms. So today I'll be talking about charting a career of consequence as a physician. And the beginning of my journey towards becoming a physician pretty closely followed what I thought was the become a doctor playbook. My first memories started to answering the question, what do you want to be when you grow up? With the answer pediatrician when I was about, 4 or 5, which is how old one of my daughters is now. And at that point I was getting a lot of positive feedback. And so I just started down this playbook path of doing all the right things. I studied hard, got good grades, I did some research, I helped people in my spare time. And then of course was very fortunate enough to land at Carolina as a Morehead-Cain scholar, where I stayed on that path. I was pre-med, I was a biology major. And I thought that if I wanted a career of consequence as a physician, I needed to stick to that plan of following that playbook that I sort of had in my mind that people had counseled me on. And that included spending my Morehead-Cain summers doing something extraordinary in health. And so for any current scholars who are on now or listening to this later who feel that same pressure, rest assured that you don't need to do that. Ultimately, the thread that ran through my summer experiences was not medicine, but actually working in Spanish-speaking countries. And those experiences and the skills gained, both in working with different cultures, communities, and of course, learning Spanish, have shaped my clinical practice and also how I've been able to make meaningful contributions in working with the Latinx communities throughout my career. In my time since leaving Carolina, I've encountered 3 pivotal intersections when my career course definitively deviated from what I knew as the usual career path of a physician. Common to these 3 pivots, which I'll be describing, were observing that something was just not right in the health-related world around me, and then finding the confidence, courage, and the right opportunities to act on what I saw as not right. And I want to give a huge thanks to the Morehead-Cain, mentors, friends, and family for helping me build that confidence and courage to change directions. So the first pivot. This is when I was being exposed to clinical care for the first time as a medical student. I certainly felt both that feeling of gratitude for being in the very privileged position to be helping people with their health, but also pretty quickly got frustrated because it became clear to me that there were things well beyond what I could address when I was sitting in a clinic room with a patient. Things like when I saw patients who seemed so committed to wanting to improve their health and be healthy, but couldn't get their diabetes or heart disease under control. There were clearly other things going on in their life that were preventing them from achieving those goals. And so I felt compelled to move one level up in my goal of improving people's health from the individual level where I was working one-on-one with a patient sitting in front of me up to the population level. And ultimately, what that looked like for me was joining a training program at the Centers for Disease Control and Prevention, or CDC, where I learned the ropes of public health, not from a classroom like doing an MPH, but through experiential learning, where I had the opportunity to study things like who was getting the HPV vaccine in the United States, and even more importantly, having the opportunity to sit in the room with a pretty small group of public health experts who were writing the policies and making recommendations that changed how millions of children had access to and got that HPV vaccine to prevent cervical cancer. This compelled experience of diving into the public health world as a physician trainee shifted my career towards one in which I continue to work both at that individual level, now with teens and young adults because I specialize in adolescent and young adult medicine, and at the population level in a variety of capacities, which I'll describe. That focus on policy and populations while I was in medical school led me to the second point in my career, where I again felt compelled to act and do something outside of the usual physician playbook. At this point, I had completed all my years of medical training and I was in practice as an adolescent and young adult pediatrician at Duke, which is where I continue to practice now. And at that point, I was more back in a commonly taken, I'll call it an avenue for physicians. I was a physician researcher at Duke, a large academic medical center, where I was spending most of my time doing things like clinical research, getting grants, and seeing patients. But I was becoming impatient with the pace of traditional clinical research, particularly as I started getting more involved on the policy front, thinking about things like, how can we redesign how we deliver care that will help more children? And importantly, how can we change how that care gets paid for? As I was feeling that tension of wanting to do more and do it faster, the right opportunity presented itself. The federal government released an opportunity to pay for and fund the design and implementation of a really innovative system of care for children, specifically our most vulnerable children in North Carolina insured by Medicaid, including many of Latinx children for whom I had been having my clinical practice with because of my Spanish language skills. This opportunity would put into practice some of these concepts of transforming care and payment that I'd been writing about and speaking about, but that not very many people in the country had actually been able to try to actually do for children. And now that's what we're doing. It's in what's called the North Carolina Integrated Care for Kids, or NC Inc. model. This is a joint effort led by Duke, UNC, and our state's Department of Health and Human Services. And together, we're on a quest to partner with communities to support and bridge a bunch of child-focused services, like children's health care alongside schools and early care and education and child welfare, and organizations that provide food and housing to children and families. And we're aiming to improve children's health and well-being by integrating these social drivers of health into the model and the systems that serve children, and also change the way that healthcare providers get paid to do this type of more integrated care. So now I spend half my time leading a team and a broad coalition of healthcare and community partners in this NC Integrated Care for Kids work. The third and final pivot intersection brings us to the present and, of course, the COVID-19 pandemic. The COVID pandemic, for me, like so many others, and I listened to Jed's talk where he also talked about the impact of the pandemic on his life. The COVID pandemic was stretching me to my limits. I was working harder in my career than ever while juggling increased demands at home with two pretty young kids who were out of daycare and one getting ready to start remote kindergarten and who is in remote kindergarten now. As I was working too late into too many evenings, I was questioning how I wanted to be spending that time, wanting to ensure that those hours of lost sleep were really making a difference in these really scary and unpredictable times where there was certainly too much not going right in 2020 in the world around us, but also acknowledging that I was already stretched so thin. So what else could I do, or what else could I take on? And so my last pivotal intersection happened recently when I was asked to come and help lead the COVID-19 response for the state of North Carolina, an opportunity that some of my prior pivots had actually prepared me for, like working at the CDC and gaining these public health skills. That's what I'm doing now with the other half of my time. And I had to make some really hard decisions to step away from many other important roles and projects that were very near and dear to my heart to be able to take on this new role. It's an absolute honor to be serving in this role right now, which feels among the most consequential in my career. And as an added bonus, I'm working alongside another cousin, Madhu Vulamiri, class of 2014, who also happened to be my partner in crime as we were developing the NC Inc. model. And we're both working under the leadership of another cousin, Governor Roy Cooper, class of 1979. And so while I'm definitely a planner, and the title for this talk, Charting a Career of Consequence as a Physician, hints towards a lot of planning, being very intentional, my journey has not been one that followed what I thought was the playbook to leading an extraordinary life as a Morehead-Cain alum. Instead, my journey has been driven by what I observed in the world around me from my vantage point in that moment in time, as a medical student, as a practicing physician researcher, as someone working in policy. And then finding the courage and opportunity to do something more, to make a difference in improving someone's, or hopefully a lot of people's, health. Thank you so much.
Thank you, Charlene. Awesome. I'm sure folks have questions for Charlene, and you're welcome to either just unmute yourself and chat. Tom Morris, that looks like a clap, but maybe it's a raised hand. I couldn't tell. But feel free to chime in if anybody has questions.
I have a question. Charlene, I couldn't believe that you are able to do the COVID North Carolina responsibility part-time. Talk to us about making those choices, and you did say I dropped some important things, but go ahead and start from what are you still doing as a doctor while planning for the state?
Well, the main thing that I did keep, which is taking half of my time, is that NC Integrated Care for Kids model, which I see Madhu on, and I just want to call her out again, because she and I really, I think we birthed this idea together, which we are now doing for 100,000. We are developing, and we're going to do this, have a new little system of care for 100,000 Medicaid and CHIP-insured children in Central North Carolina around Duke and UNC. And that was one I thought really hard about, would there be a way for me to step away from that for a period of time to be able to fully dive into doing the COVID role full time. And we're just launching. We just found out that we were awarded the opportunity to do this model a few months before COVID struck. And then COVID happened. We have a 2-year planning period in NC Inc. before we actually launch this new little system of care for children and families. And there just wasn't a way for me to be able to step away from that, because we're at such a critical point in that project, which is, besides working on the COVID response, certainly the other project that feels the most consequential and important to me. And so with that in mind, I made the choice to decide to do half-time with the state and half-time working on North Carolina Integrated Care for Kids, and working again with Madhu at the state, really working to make sure that what I'm scoped out to do at the state is about half-time. I think, as everyone knows, it is not really a 40-hour work week. And really trying to make sure that I have balance. I will also say again that I gave up a lot of other things that I was doing, and also we have a lot of help at home, both from my husband and my extended family, and trying to bring help in as safely as possible. But that was certainly a really hard choice, and I don't claim to have found the perfect equation for balance.
So in my absence, I may have missed some of this, but I would love to hear more about how you are. I mean, a little more about balance. The reason we go back to this is you'd be surprised how many of the current scholars have this as a high priority of things they want to hear about from their mentors, from older Morehead-Cains. How do you do it all? And I guess my question for you is a little more about what your arrangement is with your children and keeping them in school or out of school, or however you're doing that right now. And then after that, Tom Morris has a question for you.
Yes. So first of all, I'm not doing it all. I guess I should have said, Jane, to your question, one important thing I didn't say is I have essentially stopped seeing patients for the next couple of months as I took on this new role, which is very recent. I'm still seeing a little bit and keeping tabs on and being available to some of my longer term patients via electronic health sort of messaging and such. But I'm doing very much less than I used to, just because there had to be time made in the week to be able to do all these different pieces. In regards to what we're doing with our family, we have a remote kindergartner and a remote pre-K-er. Those are like oxymorons, because you can't really do pre-K and kindergarten remotely. Developmentally, as a pediatrician, I will say professionally, it is very challenging to do pre-K or kindergarten remotely effectively. So we actually, this Morehead-Cain family coming back around here, we host a learning pod at our house with one other family, and it happens to be the family of another Morehead-Cain cousin, Tommy Thecka-Candom. He and his wife have 2 daughters who are about the same age as our 2 children. And so we have 2 pre-Kers together, a kindergarten and a first grader. And we have a wonderful set of nanny teachers who help do that. Though I will say we as the 4 parents are quite involved in doing things like planning an enrichment curriculum. We took a little field trip to the park today in between meetings. And so, certainly it is very different than what things would have been if they were in-person pre-K or in-person kindergarten. However, in the position that I'm serving in the state now, along with people like Madhu, we have the opportunity to really try to help move our state towards opening our schools and childcare centers as safely as possible, as quickly as possible, which is certainly something that I have been advocating for with many others, because schools, in case anyone was unaware, serve a very essential role in our societies, same as grocery stores and healthcare systems. And the question should not be, should we reopen our schools? It should be, how can we reopen our schools? Which is something that I've been doing some writing about. And of course, now at the state, trying to help move towards being able to do so, again, as safely as possible for all students, staff, families, communities. Shall I take Tom's question?
Tom, sure. Tom, do you want to ask it yourself, or do you want to?
Yeah, well, I was going to ask it just by chat, but I'll ask it in person. Thanks, Charlene. This is a great session. You're surrounded by Morehead-Cains wherever you go, it seems like. I wanted to ask, what's been your single biggest challenge in leading the state's COVID response? What's been the hardest thing for you? And how have you managed your own emotions and attitudes as you have confronted whatever that challenge might be?
I will say at this moment in time, the biggest challenge is that I have joined a team of really phenomenal people who have been working around the clock for many, many months, leading this COVID response. I should say, I feel like I am contributing to leading the response. I am not leading the response. And the biggest challenge at this moment in time, because this is a very new role for me, is being able to get up to speed with what has already happened in a landscape where so much is changing so quickly. And that has been a big challenge. And of course, most of us are working remotely. And so trying to create those relationships, the trust, figuring out who everyone is over Zoom calls like this, where sometimes people come on camera, sometimes they don't come on camera. So you're just speaking to a name that you see in a box. And I would say at this point in time, that feels like the biggest challenge. I think sort of at a more macro level, the biggest challenge, and it sort of relates to Gregory's question, is trying to figure out how to prioritize where I spend my energy. There are a lot of things, both in the COVID-19 response work at the state, in the work that I'm doing, leading the North Carolina Integrated Care for Kids model, the things that I need to do at home here outside my office door. There are a lot of competing priorities and trade-offs that happen with each decision for, am I gonna help make this slide deck that is gonna feed up to the governor? Am I going to spend some time trying to use my thinking power to develop a new framework that will help sort of operationally across some of the things we're doing in COVID-19? On NC Inc., we're interfacing with so many different stakeholders. Where do I need to put my attention, and where can the team really be effective without me needing to sort of step in? So it's really the prioritizing of time, which is, the most valuable resource at this point, I think.
It sounds like almost like chaos management every day, right? There's so many moving pieces. My life seems so simple by contrast. Am I going to read Plato, or am I going to read Aristotle today? So I really admire how you're able to balance, juggle all these things at once and make forward progress.
I'd say it feels more like juggling, maybe not balance, but there's certainly a lot of juggling.
Yeah. And didn't one of the former talks, I think it was one of our cousins who said, don't drop the glass ball. Whatever ball you drop, you've got to figure out what the glass ball is and don't drop that. That's really important in prioritizing the juggling act, you know.
Yeah. And I'd say for me, and this gets to Gregory's question, which is the glass ball is, for me, family. And, you know, my daughter, for example, is in remote kindergarten. Luckily, it's going really well. She loves it. She's never been in school otherwise. I don't know, maybe that was like a blessing in disguise. She didn't know what it was supposed to be like. But, you know, to me, that's the glass ball that can't be dropped, is making sure that our kids and my husband are like, have the things that they need, but particularly our kids, because they are quite young, and trying to sort of help make sure that they're adjusting and getting what they need to be healthy, happy, learn some things, learn some pre-K kindergarten things like math and reading, you know, those basic sorts of skills.
Yeah, that's good. Good.
And then I think, Gregory, to answer otherwise with your question, you know, one thing that I try to do to take care of myself, for the self-care piece, because I think that is another glass ball that too often does get dropped. And I think we as physicians, I mean, there is this saying, and I think it is sort of true, we are the worst at taking care of ourselves, is I do try to carve out 30 minutes each day, which are like sacred time for me, by myself, and treat it like one of my mentors told me. She said, treat it like how you get treated when you're in clinic. Like, people, no one bothers you when you're in clinic, or if they bother you, you don't get back to them. Like, no one's like, oh, why didn't she get back to me, right? You're like seeing patients. It's a little bit of like a sacred time. And so I try to carve out 30 minutes each day to do that, ideally outdoors when possible. I am not always successful, but certainly that's what I try to do. And Chuck, yes, Madhu and I would love some Morehead-Cain interns. If there are any scholars who are on the call now who are interested, we would be interested in having you join our team. I will say we would do the same for our North Carolina Integrated Care for Kids model. We would also take Morehead-Cain interns working on that with us.
What kind of work could they do for you?
So many things. And Madhu, I'm just going to tell you, I'm going to put you on the spot. So if you have anything to add to what I'm going to say, I mean, I think in the COVID-19 response, depending on how much time people have available, we are needing to make decisions so quickly every day about, should we reopen this? Should we do this to enforce the fact that people aren't wearing masks? And having help to even just to be able to look out across the country and around the world, what are people doing? There's so much data coming out every day. It's just hard to stay on top of, oh, this new study that just came out that showed this enforcement strategy was really effective in Oregon, you know, and trying to sort of keep on top of that. So I think there could be just some synthesizing of information. We're also creating, like right now, creating infographics around the upcoming COVID-19 vaccine. I could imagine working with a very graphically talented Morehead-Cain intern who would help just like vet from a more layperson perspective, like what should that look like? I mean, I could imagine there's a lot of different ways, but Madhu has been in this since the get-go. So I'm gonna turn it over to her for a second and see if there's anything she would add or amend to what I said.
I think you got it right, Charlene. We're trying to make decisions very quickly, and it really helps to have additional eyes to extend ourselves we do a lot of research and thinking about what other states are doing and what we can learn from them, in addition to thinking about how we want to be leaders in North Carolina. So there's no shortage of things that we could use some help on. So.
And it would be the same for the NC Integrated Care for Kids model. We have a lot of students and trainees at all levels, from undergrads through graduate students and postdocs who are working with us on that. It is one of the benefits of having brought Duke and UNC together for that, not just Robertson Scholars. Now we're doing this thing together for children around our two institutions. And we have a lot of student teams and groups from both institutions who are working with us on that in a variety of capacities.
Ruben, would you mind asking your question yourself? We'd love to have you on camera.
Oh yeah, sure. Hey, Dr. Wong. I was wondering if there's any skill-based virtual training or like video games available for younger kids or adolescents to help them learn skill-based public health habits very quickly. The reason I was asking that is because I'm a senior biomedical engineering student here, and we're trying to brainstorm different ways to help out with the situation. And I felt like it was abundantly clear that, with this situation, we don't have a quick modular way to get a bunch of people on board with behavioral adaptations in their life quickly. So that's kind of where I'm asking it from.
Yeah, so for example, Ruben, if you wanted to develop something, so we are developing, at the state, different educational modules and that other partners have developed to help educate not just children, but everyone that's needing to change the way that we operate our businesses, that we operate our schools, that we run our households and ask our family members to do different things. So, I think that sounds great. I am not personally aware of a really fantastic tool for teaching children that. The one thing that I do continue to emphasize when I'm doing any press or anything like that is that for children, we need to be very cognizant of their developmental needs, because obviously my kids who are in elementary school and what a high schooler would both need and want are very different. And so thinking about sort of at which ages those would be the most useful. The thing that I keep coming back to with, because we get asked a lot as pediatricians, what can we do to help our kids, do the right thing, get ready to go back to in-person learning. To me, the biggest thing we can do is to model for them what the right behaviors are. So these are the 3 W's: wear a face covering, wait at least 6 feet apart, wash your hands a lot. And particularly with the mask wearing, because that is something that is very different, but that we are seeing many schools and even in younger children be very successful with, and making sure that we are setting the social norm in our communities, that this is what we do, so that when they go to school and they're wearing a mask and their teacher maybe has to remind them, it's not like this foreign thing, well, I never wear a mask otherwise, my family doesn't ever wear masks, so why am I getting asked to wear a mask now? But I think that social norm behavior is so important.
Thank you.
Gare, same thing. Would you mind asking your question? Be great to have you.
Hi, Charlene. I'm your colleague at Duke over on the university side, and we sort of hold our breath every day, right? How long is this going to last? Do you have insights as a physician about what has made the difference for different campuses and their outcomes, because there is such wide variation?
There sure is. And I would say Duke is being held up as an exemplar right now, because Duke as a university has done incredibly well, certainly an outlier in how well Duke has done in keeping cases down. I think that there are some best practices that we can look to at certain universities, and then also on the flip side, look to maybe strategies you would want to avoid, or approaches you'd want to avoid in some of our universities that haven't done quite as well. So for example, Duke was very early in, or not very early, but did de-densify. When we were having students come back to campus, it was not everyone come back, fill the dorms up. And so there was this de-densifying of the dorms, which certainly makes a huge difference, because COVID, when you put people close together without masks on, that is how it spreads. And we certainly know it has a propensity to spread in young adults, because that is where we were seeing the greatest growth in our number of COVID cases. So that's one thing that Duke did. A second thing that I think they did very well, and I know I'm talking to a Tar Heel here too, even though I also work at Duke, that Duke did very well, is they made it very clear, very transparent what the expectations were for students, for faculty, for staff, for everyone who was coming onto campus. What were the expectations around things like mask wearing? They actually put this thing together called the Duke Compact that we all signed, that had it sort of very clearly laid out what everyone was going to do. And they used both carrots and sticks, and also social sort of norms to help promote these behaviors that are difficult to do all the time. So for example, they have student sort of champions of wearing masks, who are sort of going around campus helping, encourage people, reminding people, giving out things like Starbucks gift cards randomly to people who are doing a great job, right? There are also some enforcement sticks in place for when students and others aren't following those. And those are very transparent to students. This is what will happen if you're not following these. I think the other big thing that Duke did that was different than what some of the other universities were able to roll out as quickly was widespread testing. Widespread testing. Sort of upon coming, before you could come back onto campus, you got tested, and then students and faculty and staff are getting tested regularly, and there's like testing sites all over campus to make it very easy. And so I think those are some examples of best practices. And those are the types of practices that now we at the state and the universities talking to each other are trying to spread across more universities. And of course, we're not alone in North Carolina. We're seeing these same patterns play out across states in the country as universities have tried to reopen.
I'm sorry, I'd love to ask a follow-up. Is it part of your conversation recognizing a tipping point or a changing point? I know there are a lot of very sad students at Duke who are staying healthy, but are suffering, their mental health is suffering. At what point does, is it even part of the conversation that we start weighing that in the balance and changing our approach?
I think certainly, I think it is part of the conversation. I will say, like, just sort of broadly from where I sit as a physician and, you know, as a member of the clinical research community and also now in the policy community, not just in the role that I'm serving in the state right now, but as the broader policy community. Certainly there is a huge concern for the parallel pandemic of mental health. And I think, again, I think about young children a lot because of course I've got young children here, and their social emotional health, that is what they go to pre-K and kindergarten for. A lot of it is to develop that social emotional learning, which is very hard to do right now. And so I think we'll be learning a lot for a long time about sort of what the, you know, long-term impacts of the pandemic are. I will just add, not to be a total downer, but, you know, I also, what keeps me up at night are things like we've seen cases of child abuse go up because of this pandemic. And, you know, I've been asked by reporters, is this going to be an adverse childhood experience? Will the pandemic be an adverse childhood experience? My answer is, for some children, for sure it is. Like a child who has been abused because they didn't have adequate childcare during the pandemic, like this is an adverse childhood experience for them. And the more that we can do to reduce the number of children and citizens who sort of experience that, the better. And at least for me, I'll just come back to, I really, the push that I see, and also what keeps me up, are the inequities that are just being so horrifically exacerbated by this pandemic. To me, getting schools back reopened is such a critical component of what we need to do, because again, specifically for our younger children, all the pieces there. I also want to say one other thing about colleges, which is that, and I wrote an op-ed about this recently actually, because I was so fired up because I just felt like the media and UNC was right in the middle of all of this, because of course there was just a massive amount of coverage of the outbreak that we had on campus. You know, I just felt like college students as a generation were being scapegoated as these like horrible, selfish, careless, like generation who were the ones who were perpetuating the pandemic. And first of all, the data does not support that. The pandemic is being perpetuated by many different things, most likely across all states. And second, the point that, you know, I continue to try to make is that in many cases, our students were set up to fail, right? We're like, come back to your dorms that were designed to bring people together. Come back, but don't get together, even though they were designed to do that. Come back to this university where we encourage scholarly and social gatherings and, you know, intellectual discussions, but don't really talk. Or if you're going to talk, stand really far away from each other and wear a mask. You know, and when young adults, when we think about youth development, brain development, we know that young people in their college age years are developmentally wired to actually take risks, and that's a good thing. This is how we like become the adults that we are. And writing about instead and talking about and supporting leveraging the energy and the passion that college students have and other young people have to actually help respond to the pandemic. So like Ruben, like your idea, you're like, you know, I was thinking maybe I could use my skills to develop some great game so that kids could learn, you know, what they should be doing. And you don't have to look very far to find examples of this. And I don't know if UNC students have started something like this, but like in Tennessee, they've got this huge tutoring corps where college students in Tennessee are tutoring mostly disadvantaged younger students who are also really struggling during this time, not coming onto classes, not being able to follow what's going on. You see a lot of college campuses really helping address some of the food insecurity issues that too many families and children are facing. So I'll just sort of add that as a positive way to think about, let's be solutions oriented when thinking about our college student population.
So Dr. Tuttle has another question for you, Greg, about the work you do.
Hi, Charlene. Very impressed by the many facets of your work and all that you're doing over at Duke. With my background in family medicine and emergency medicine, of course, I saw all age ranges through the emergency room, but the majority of my career was spent at UNC in campus health service. So, you know, my adolescent population basically started in the, you know, mid-teens to 30s, basically. And I was just curious, how far does your work extend age-wise over at Duke? Yeah.
So clinically, I see patients mostly aged 12 to 26. And this is, I think, to one of the early questions, like, you know, how do I prioritize and balance? I also I'm like, okay, this is my sweet spot. This is where sort of clinically, I feel like I have this unique lens because I am in the privileged position to be able to talk to these teens and young adults that can help inform what I think we should do in policy. And so even at the state now, I'm getting to do some of the work on college, you know, what's going to be our response in colleges and bring some of this positive youth development lens and a strength-based lens to how we're thinking about that, which feels, again, like a real privilege. So I sort of try to focus there. I also have a portfolio of work that is just in really more adults. And then at Duke, I have a portfolio of work that's just in kids, some of which are much younger, including in the integrated care for kids model I mentioned, NC Inc. We do have a huge focus on early childhood because there is so much to be gained by doing more in early childhood. And so it sort of runs the spectrum, but I do have a very, very, very sweet spot in my heart for the teens and young adults.
Do you work with anyone in or through the campus health there at Duke? Do you see Duke students and grad students and fellows and that sort of thing?
I do, very peripherally, though. I will say what I see the most is Duke faculty and sometimes UNC, Duke faculty and others who choose to come to our clinical practice. I'm a primary care pediatrician as well as a specialist whose teen, young adult children are needing a primary care pediatrician, and often, especially as they're getting into young adulthood, they are students at UNC or at Duke. So that was sort of when I was first hearing about what was happening at UNC. I had a patient come in for her just usual, you know, annual checkup, and she had just moved into one of the dorms I think it was on North Campus, and she was like, Dr. Wong, let me tell you, I've been there 3 nights. There have been parties every night. I'm really worried about my health. And I was like, oh man. And this was sort of before everything really like blew up in the media. So.
Yeah, there are challenges there. Absolutely.
Yeah.
Yeah. Thank you.
Other questions for Charlene?
I have a question. Hi, Charlene. That was really fascinating, both your personal story and the way you're talking about your current work. You've mentioned a number of times what you see as just the imperative of getting schools open. Can you summarize what you think is required for schools to open safely? And I'll just say, I'm actually in London, and my son is at school, so he is in in-person school. So I'm witnessing it. He's already had 1 week at home because of a COVID case. But what do you think are the priorities for North Carolina to get for you to feel comfortable that schools are safe to open, both for teachers and for students and for staff?
Yeah, great question. All right, number one, we must get our COVID rates down. So all these COVID metrics, we got to get those as low as possible. And that means that everyone doing the 3 W's, the masks, the whole thing. That's number one. The second is we need to resource our schools adequately so that they can do all the other, we call them mitigation measures, all the other things that they need to do to keep students, staff, communities as safe as possible. Things like ensuring that they have enough masks and cleaning supplies to do the more frequent cleaning that they need to do, that they're able to squeeze the classroom sizes down so that they can have these like cohorts of children who aren't interacting with each other, which sometimes means requiring doing some creative work with the space that they have available, some creative scheduling, creative staffing to do so. We know that our schools in the United States are underfunded, and so this would require an infusion of funding to be able to effectively do that. And then I think third, the point I will make is that when we think about the role that schools serve in our society, I've already said, they serve this essential role. It is number one, of course, education. That's a thing that people always think about. That is a critical and essential role that they serve. The other very important one, which I've alluded to multiple times, is they provide childcare. They are the most common source of childcare for working parents and caregivers because for those hours that your kids are in school, they are somewhere that is safe, for the most part, very safe. But they also do other things, and I'm sure you all are aware, right? 30 million children in the US rely on schools for free and reduced lunches to get adequate nutrition. And then also within schools, there are actually a lot of healthcare services and other ancillary services that are provided. Mental health therapy, occupational therapy, physical therapy, or kids who have special learning needs. So there's just a lot that is delivered at school. And so I just wanted to highlight that also as a reason that they are an essential service in our society. And I think probably don't need to convince anyone on this call of that. But I would say those are like the two pieces, going back to getting our COVID rates as low as possible, and then making sure our schools are adequately resourced so they can put all the pieces in place to do it as safely as possible.
And when do you think that might happen? I mean, the latter piece seems harder than the former.
Well, I don't know. They're both pretty hard. I think, we are seeing across the US and in North Carolina too, our numbers are not, they're no longer going like down the way that we would hope. And it is what we expected. We are moving into flu and viral season, colder weather when more people are having to spend time inside. So we do worry about that. And I think the second piece, it requires the action of leaders. We need stronger leadership in the response. And that needs to be driven at all levels, but certainly at the federal level. And that requires massive funding to do this at scale. And again, when thinking about those inequities, it is the school districts where we have the greatest number of children who are not signing on at all, signing on cracked screen phones, which I've had some of my patients show me that's what they're doing their schoolwork on. They do have a mobile device, but the screen is all cracked, and that's the only device that they have available to them. They don't, too many of my patients don't have broadband access. Maybe the school gave them a hotspot, which is wonderful. But as we know in North Carolina, like so many parts of the country, very rural. So even if you give a child a hotspot, if they don't have enough signal at their house for that hotspot to work, it's not particularly effective, especially for being able to get on video. We know those visual cues are so important. So again, it really does come down to leadership and resourcing.
Do you think it'll happen this year?
I'm an optimist. I'm an optimist at heart. So I do think it will happen. And in fact, in North Carolina and across the country, we are seeing more school districts open. we are seeing, like we were just talking about, you know, Gare, to your question, there are schools, just like there are universities, who have been very successful and have proven this is possible. It is possible. You even look at summer camps. There were a lot of summer camps operating where they were very successful. Of course, there's a lot of press of all these places that weren't successful. So I do think it'll happen. And in fact, in North Carolina, we are seeing more schools opening with each week. And so we hope that that will continue.
All right, I think we have time for one more. If anybody has a final burning question for Dr. Wong.
I have a question. So when you were talking about the food insecurity that has increased with school closures, besides reopening schools, are there any other healthcare policies or just policies in general that could mitigate that effect?
Yeah, and in fact, this is a place where there have been actually a lot of great moves in the policy space, as well as seeing communities really come together. Let me start with the policy first, and then just give some examples of some of these local efforts that have, I think, been reasonably effective. Could we do more? Yes, always. But at the policy level, there have been, for example, in North Carolina, and it's called EBT, Extended Benefits Benefit. Basically, if your child had previously qualified for free and reduced lunch, there would be additional dollars put onto your EBT card that could be used to buy food at approved vendors, which is most of the like major grocery store chains. So that type of policy is putting cash directly into families' hands who need it to buy, to make sure that there's adequate food for their children. Our state also happens to have a really fantastic platform called NC Care 360, which is also available. It's basically a community resource repository whereby physicians, others who are onboarded onto the platform, can make referrals when they identify someone is in need of food. There are also food providers that are a part of this platform, so that you can make a referral and say, Johnny and his family need food, and that goes out into the world, and then a food provider on the other side grabs that referral and then delivers services, and then you, the person who made the referral, gets to see that that loop was closed, that referral loop was closed, and Johnny and his family got food from Food Bank X, for example. And then I think the third piece, the second piece, you know, that is that we've again seen so many local efforts that have been really effective in bringing together resources from communities and delivering that out to those in need within their communities. And again, I will just point again to college students, where if you look across the country, you just do some quick Googling, food resources college, you can see there have been so many organizations, student-run organizations, student-led initiatives that are doing that work in the communities. Some right in North Carolina and at UNC, some of which were started by some of our other former cousins. So.
Wonderful, thanks for that question. And I'm sure all the scholars are going to be very interested in hearing more about maybe some opportunities to work with you. So I will be following up with you and Madhu to see if we can get those on the MC Network. We're really excited. Charlene, amazing opportunity to spend some time with you and kind of get a behind the scenes look at your life as a physician and your important COVID-related work. Thanks so much.
Thank you guys so much, and thanks for the great questions and discussion.